Welcome to the Birth Lounge Podcast, an empowering space for expecting and new parents to hear candid conversations with experts and learn how to craft your ideal birth. We will tackle the scary and weird questions that come up along the way and provide answers that are driven by science and evidence-based recommendations. I'm going to show you how to redefine parenthood and choose what's best aligned for you and your goals. With 10 years of experience in family education and a master's degree in human development and family studies, I'm ready to help you navigate pregnancy and explore your birth options to free yourself of fear surrounding childbirth. My goal is to help you have an informed and confident labor experience, plus an empowered and joyous postpartum. Áine, welcome to the show.
Hey, Hee, thank you so much for having me here. I'm so excited to talk about this topic today.
I'm very excited to have you. I think this is a topic that a lot of people are going to feel like it has impacted them in some way. And if you are someone who hasn't been impacted by baby reflux, really, I'm glad for you. We love that for you. But for the people who have been impacted, I think we all kind of have this cringe of like, oh, it's such a struggle. And it can be really, really hard. It's hard, especially in the US to find accurate information. And then it's always hit or miss whether your pediatrician is kind of knowledgeable about baby reflux, and also what is their approach? Do they have a flexible approach, or do they turn immediately to pharmacological kind of resolution? So I think parents are eager for a conversation about reflux, and I'm really excited to dive into this with you. So can we start a little bit just what is reflux, and how do we tell reflux from normal regular baby spit up, because spit up is a normal baby thing?
Oh, I love that question, Hee, because I'm going to question whether spit up is a normal thing or not. So let's get back to
Yeah.
basic questions. Reflux is regurgitation. That's all it is. It is the movement of stuff from a baby's tummy or from anybody's tummy into the esophagus. Sometimes it comes into the esophagus, sometimes it comes up as far as the mouth, sometimes it goes beyond the mouth as like vomit. Some babies even projectile vomit. It's all reflux. And
Mhm.
for people listening, if they think their baby has silent reflux or they've been given a diagnosis of silent reflux, the only difference between reflux and silent reflux is that silent reflux only comes into the throat, so we don't see it. It's not about hearing it, it's just that we don't see it. Everything else about it is the same. It is the movement of stomach contents into the esophagus or the food pipe for baby. And lots and lots and lots of children are given a diagnosis of colic early on, or even pediatricians use the phrase purple crying to explain unexplicable crying.
Yeah.
It is my belief that every single baby is crying as a form of communication.
Yes.
And then it's about figuring out, well, what are they trying to say? Some of them are saying, I need a hug. Some are saying, Mom, where are you gone? Some are saying, I'm hungry. Some are saying, something hurts. And it's just one piece of the puzzle. Lots of babies have ongoing digestive discomfort, so they have no regurgitation whatsoever. However, because everything else appears physiologically normal, so they're gaining weight, they're sleeping fairly okay, they're still feeding hit and miss, but it's okay. So there's no external, obviously something wrong with them from a medical point of view, but they get diagnosed as having reflux
Mm.
because the medical community are taught that reflux is normal. And it's really important to know that our pediatricians and doctors are taught that something is normal, therefore that is their belief. Just because we want to take a different look at it doesn't mean that we're anyways wrong.
Yeah.
It's okay to look for further answers and for explanations. And what I encourage every parent to do is, and I think this aligns with your work as well, Hee, is to interview every single person you meet, be it a public health nurse or a pediatrician or a midwife or a lactation consultant or me or an osteopath or a chiropractor. Interview everybody and go, I think that bit fits for my baby, but that bit doesn't. And bring together your own village of help to be really specific for your child, because every single human is different.
Yeah, you touched on looking into other options and it just like prompted me, like dropped into my head to say if your gut instinct as your baby's parent is pushing you to look into other options, you should listen to your intuition. Do you know how many people I tell on a daily basis? You know your baby better than anybody on earth, and you may feel like you don't really know this tiny human, and that may be true. You may not know them deeply. They may only be 5 days old, but you know them deeper than anybody else on earth for those 5 days that they are, for those 14 days, for that month, for those 2 months, for their 6 month. Like you will never not be the expert in your child. Look into those gut feelings. Okay. And I love the way that you say put together, we call it in the Tranquility by He community, your own equation. So take what fits for you, line them up in your toolbox and say, here's my perfect equation. And then if one of your pieces of your equation breaks or isn't available or becomes not an option, have alternatives for those. So I also love to guide parents to have almost a hierarchy of options that they want to look at. This is my first choice. And if this one doesn't work, then I'd be most comfortable moving to this. And then I'd be most comfortable moving to
Mhm.
this, and you know the different pivots. Well, if this happens, then we might have to skip that one because, it's not appropriate anymore.
Yeah.
Yeah. Gosh, I really love it. Okay, so well, hang on, before we move into that, let's talk about normal spit up. So, let me share my belief about spit up. So, my master's is in human development and family studies. So, I look at anatomy a lot. And your baby is not born with that esophageal flap. And so a lot of times we will see babies do what a lot of people refer to as happy spitting, but it's just like normal, regular spitting. Your baby should not be experiencing weight loss with this, discomfort. It should literally just be like, oh, they spit up and that's that. It is, a nonchalant thing. I believe that that is normal. Anything, kind of outside of that would strike me as abnormal, but not necessarily reflux. So I have these three levels of, I
Mhm.
think, intensity or severity that I look at spit up. How do you approach spit up in terms of that?
Okay. So what I will say is it's not always that it requires intervention or action.
Right.
It's really about understanding it first. So every human on earth, we have the lower esophageal valve, which because it's a muscle, it's a ring of muscle,
Mhm.
muscle tissue in your entire child's body is not developed and not strong at birth. Okay. So this is where the weakness in the lower esophageal valve is often blamed for reflux. Well, in my view, if this was true, then every single child born would have reflux because every single child has this inherent weakness.
Mhm.
Now, the truth is, the stomach is like an elasticated bag of muscle. It's got 3 layers of muscle. And for the purpose of this, imagine it only opens at the top. Okay. It's like a balloon because the pyloric valve at the bottom is clamped shut until the stomach and the center in the stomach go, this milk, this food is ready for the next stage of digestion and absorption. So we've got this balloon, right? And we half fill it with milk. And then the stomach does its mechanical churning. So the bottom of it squeezes and the top of it relaxes and stretches. And then the top of it squeezes and the bottom of it relaxes and stretches in order to physically mix the contents with stomach juices for digestion. So if it's a balloon, I believe, and you can confirm, hey, would you be happy if I said half full balloon? Do you want to squeeze it?
Huh,
So,
yeah.
but a half full balloon will expand in parts to keep the milk within it. It's when we overfill the stomach or we overfill that balloon to its maximum capacity and then we try to squeeze it, that's when we get this overflow.
Got it.
Okay. So, for my belief that every child who has spit up might have drank a little bit more than their stomach can cope with at that time. They might have excess air in there that is also stretching the stomach along with whatever milk they're drinking. And so, this is where we look at why is that spit up happening? And very often we will see babies who spit up now and again. It might be after an intense period of crying when they were upset for some reason. And so when a baby cries, they go, And in that gasp, they fill their stomach as well as their lungs because they're just drawing in as much air as they can.
Right. Huh.
And so we're looking for these sources of possible air intake that then stretch the stomach beyond its capacity, that when it goes to churn, it's giving that sort of regurgitation, that little explosive force behind the milk that then brings that up. How does that feel?
Yeah. So would the overfeeding be kind of that green area of like normal slash doesn't need intervention type of, I guess, cause? Or would you still recommend that any baby that has spit up, we try and feed them just slightly less, maybe a quarter of an ounce or a half an ounce? Or is that what your recommendation would be?
So everything has to come down to parents' decision.
Right.
So for some parents, the happy spit up happens so frequently that it's stressful in terms of the laundry that it
Sure.
causes. So
Yep.
we do have to take a one-to-one approach, and parents need to say, how do I feel about this? Yeah, do you know what? It's once a day, we're okay. Or no, this is 15 times a day. I'm not okay with it. If you do want to take action and baby is generally happy and it's just that maybe they're drinking a little bit too much, then anything that your baby brings up, they're not getting any nutritional benefit from it because it's not inside their body. So reduce the feed by that much. That's one really simple intervention. Winding is a way to get rid of air before it becomes a problem. And most people, we are, well, certainly in the UK and Ireland, we are led to believe that birthing a baby is reserved for feeding time. But baby can inhale air all day, any
Hmm.
time of the day. We do it when we're talking, we do it, babies do it when they're crying. They do it depending on how good they are and what their latch is like with their pacifier. They can do it with that. So we can also birth them at any time of the day. So we can birth a baby before feed to reduce the size, the volume of stuff in their stomach before they even drink milk.
Hmm. So for babies who, now my wheels are turning. So for babies who we feed them, we burp them, and we do upright time, and let's say it's a significant amount, an hour and a half, and then we lay them down, and an hour and a half to 2 hours later they spit up all of this milk. Reflux, normal, we overfed them. What in the world is that?
There is always something else going on. And I can't say right now whether that's down to an allergy, whether that's down to air intake, whether that's down to the endocrine system and stress levels and things like that. What I can say is that we always take a step backwards. Like, my belief is for every child, and it doesn't matter what age of client I'm working with, be them, 2 or 3 days old or 5 years old, the first place is information gathering. So we look at gathering every single symptom, behavior, and thing that can happen in your baby's life. They're all the pieces of the puzzle.
Mhm. Mhm.
Okay. And we turn the pieces over so we can see what they are. And then we use a reference picture going, okay, so when we've got all the pieces together, let's say we're doing 1,000-piece jigsaw. The medical profession tend to grab a few pieces out of the box and see if they can get things to stick. They don't bother turning them over to see them all the right way up. And sometimes they'll be lucky and they get some pieces to go together. And most times it's not really going to work. I get parents to turn over all the pieces, colored side up, picture side up, and we then have the reference picture as well. So all we have to do is get 3 or 4 pieces, and depending on the type of piece, you might only need to put two together, and you're like, oh, this is a pink bit with a bit of green. And when I compare that to the picture, I know exactly where it goes. I know what orientation it goes in. So we can tell a lot when we've got all the pieces together. And we don't need to spend the whole time putting everything together in order to know, right, these are some of the next steps for each child. However, if we don't turn over the pieces, we could be mixing up something so badly. It could be as bad as doing an impossible puzzle, with the ones with the thousands of minions on it. You're like, I don't know where to start. But there always is a way through. And so for me, it's the process is always the same, but the process gives different answers depending on what's going on for each child.
Yeah. Gosh, I love that. I talk a lot about puzzle pieces too. It's just really important that you look at your baby as individual as their fingerprint because they are. And this stands true too for siblings. So, this may be your fourth baby. They're gonna be different. They're gonna have a ton of similarities to their siblings. I recognize that, but they are also gonna have a lot of differences. So just because this is your second or third or fourth baby, don't discount something just because your first baby didn't have it, or vice versa. Just because your first baby did struggle really badly with reflux doesn't mean that your second and third and fourth babies will, unless, Anya, there's data behind that. I say that purely anecdotally, that I've seen many families have first babies that have terrible reflux and subsequent babies not. Data around that?
There's no data. And the thing is, reflux has over 30 different causes that I've identified. Okay, so in my mind, I don't call reflux a disease. The medical profession have this GER and GERD, the gastroesophageal reflux, which is apparently normal, and GERD when they add the word disease on the end. And the only difference, according to medical literature, is when the disease form causes marked distress. Now, that's not a disease in the true sense of the word. If you take a true disease like cancer, cancer has blood markers. In every single case of cancer, no matter where in the body it occurs, there is a shift of the cells from being aerobic to anaerobic. That's what causes tumors every single time, no matter where the cancer occurs. So that's a disease. It is the same pattern in every person, in every part of their body, wherever it occurs. That's what cancer is. Like COVID, there was a test for it. You either had it or you didn't. They are diseases in the true sense of the word. Reflux is a symptom. Okay, reflux is caused by something else always. And if we take, like, there's a few pediatricians now in the UK that I've been in touch with over the last number of years, have started, they're like, actually, it is more of a symptom. And when we start to look at it as a symptom to see what else is going on, then we get to identify that true underlying cause. So, for example, it could be things that happen in pregnancy. Stress levels in pregnancy can cause reflux in baby. Mums or dads, like the microbiome and the environment kids are in can contribute to reflux. The stress levels in the house can contribute to reflux. Tongue tie, oral aversions, buccal ties, cheek ties, any oral dysfunction can contribute to reflux. Intervention during birth. So ventouse, forceps, even a straightforward, I can't even remember the word now. Induction, that's it. Assistance from midwives if baby hasn't turned and if baby's breech for a period before birth, if an ECV, that external cephalic, what do they call it, movement where
Version,
baby,
yeah.
to try and turn baby, that can cause reflux. Multiples, just simply babies being squashed in utero, perhaps even having fight and beating each other up in utero, can contribute and cause reflux. And what I want parents to know is that because we can identify what causes reflux, we can address it, we can resolve it, we can rebalance the body or rebalance the environment or rebalance the food or whatever it can be. I forgot to say allergies and intolerances as well. All of these things can contribute to reflux. And so I don't believe in the standard approach of, well, let's wait it out, or let's just try a different milk and let's try another milk and let's try another milk, or let's just switch bottles, or let's have a tongue tie revision, because it's not guaranteed to work. And lots of this is like nailing jelly to a wall. It very often doesn't work. And I meet so many parents who have done all the things and they've still got really unhappy babies and no explanation, no understanding, and no learning from all the things they've tried, apart from, well, it didn't work. It could be that they've done all the right things, but in the wrong order, or for not long enough, in order to still end up in the same place that they were. So for me, getting a baby reflux free is actually a journey. And it's just like setting the sat nav in your car. Yeah, you get into your car, you set the sat nav. The first thing our sat navs do, which 15 years ago, I used to have to drive half a mile in order for my sat nav to find its GPS location and go, oh, I'm here, this is where I'm at. Capturing all of your baby's symptoms is that data gathering. This is where we're at. This is our starting point. And it's the most important part of the journey, because you then set the sat nav. Now, I assume with everybody I work with, reflux free is their destination. And so once we know the starting point, we can plan our route. You know, where are you at the minute, Hee?
In Boston.
Okay, so you're in Boston, I'm in London. If we say, let's meet in New York, and I say, do you know what? If you just head west and I'll meet you in New York, you will go all the way around the globe and you'll never get to New York. But I'll get to New York and I'll be sat there waiting for you going, but I gave her the same directions. I gave her, your directions are not the same as mine because the starting point is different. You know, from my American geography, you need to go south or southwest a little bit to get to New York. Yeah.
Yeah.
So it's a very different proposal for somebody coming from Sydney to New York. You know, they can go west. Again, they'll never get to New York just by going west. So it's really important that we get the directions. We have our starting point, we have our destination, we plan the route, and then we actually follow the route.
Hmm.
You know, it's not good enough to know that in order to get to the shop down the road, there's 2 right turns, a left turn, and a straight through the roundabout or straight over the crossroads. Because if you do them in a different order, you'll end up in a different place.
Hmm.
Especially if you're in England and we got windy roads, unlike in other states, you got lots of straight lines. We don't have that over here. So whether you take the first right or the second right is important. So,
Matters.
you know, how long you stay on that road, how long do you need to do oral play and oral support after a tongue tie revision, for example? Some people do it for 3 days, some people do it for 3 months. You know, and there is the right thing to do, which could be different for every child. And
Hmm.
that's what makes solving the puzzle difficult, is because people are grasping at straws and reading blogs going, try these 573 things for reflux. And so parents are overwhelmed. I was there myself.
Hmm.
I had no idea. I was holding my child upright. I was doing the most dangerous of sleep habits, which I won't describe because it's highly dangerous. But as parents, we do what we need to do in the absence of explanations, answers, and support.
Man, that's tough. Just like let that sit in that if people had the support, how many families could run so much smoother? Babies would be more comfortable, parents would be well rested. We could have parents that are happy and joyous to wake up. But sometimes with reflux, it's so hard. I know there's so many of you out there listening being like, yeah, I wake up almost with a little bit of dread, right? And then you immediately feel guilty for like, oh my God, I should want to spend time with my baby. But it's so hard sometimes with reflux. Like it is really, really hard. Okay, so you kind of confirmed with us that silent reflux is a thing. You confirmed with us that burping your baby does in fact help. What about upright time? So sometimes we hear of parents staying, like I say, up for 2 hours after a feed with them during the night. And now you just made your feed a 3 hour thing. Does upright time help? If so, how long? Is there a certain way that we should be doing upright time in order to ensure its success? What do we need to know about that?
Yeah. So my view is looking for what the human body should be anatomically able to do. That is my goal of normal. Okay. Just because things are common,
Hmm.
I don't believe that they're normal. I'm looking for how should the balanced, healthy human body operate? And that for me is normal. We are all designed to be able to lie down and to drink lying down. And if we're not able to keep food in our stomach when we're lying down, we have to ask why. What else is going on? What's causing this? So my goal for all parents is that you could even do, if you're breastfeeding, you could do side lying, baby just rolls over, goes back to sleep. We shouldn't need this upright time. I know for a lot of parents, they will say it's the godsend, it stops baby spilling. But if baby's spilling, they're overfed. They've got more in their stomach than they really should have. If you are doing upright time and it's helping, then great. However, there's always something else going on under the surface.
Hmm.
So my goal is always to use the process to understand, how do we unpick this so that we don't need to hold baby upright, that they can be upright for, a minute or two, a bit of burping to get any air and wind out. And then they lie down and they're asleep for a good 3, 4, 5 hours once they're, learning to stitch those sleep cycles together.
Nice. Okay. Is there anything else that we should know about the tongue ties, lip tie, buckle ties? You had mentioned them briefly,
Mm.
but I know a lot of people bring those things to our team. We have separate episodes about those ties and the problems that they can
Yeah.
create with breastfeeding. So if you're struggling out there with a tie of some sort, any sort of oral restriction, go back a few episodes because you will find the episode that we have about tongue ties and stuff. But anything that we need to know about reflux that would be important, or maybe even questions that we should ask our pediatrician, or in the US, you guys, we actually should be seeking out probably some sort of frenectomy specialist or a pediatric dentist. A lot of pediatricians don't know about this kind of stuff.
Yeah, you're absolutely right. And what I will say is across the world, the level of understanding and knowledge about how the tongue impacts our overall health and how
Wow.
important it is it seems to have been something the medical community in general have dropped.
Huh.
But as an explanation, we're using our tongues now. I mean,
Mhm.
if you try and tether yours to the bottom floor of the mouth and try and speak, it's not going to work.
Yeah.
Like it doesn't work. We use our tongues to eat. They're so important for manipulating and controlling food. They're vitally important for a controlled and safe swallow. If your child has been diagnosed with dysphagia or difficulty swallowing or an unsafe swallow, get the tongue tie looked at. I have met children who have been tube fed because of an unsafe swallow, and their speech and language therapist completely missed the oral tie that was blatantly obvious. So
Interesting.
we must always seek out proper understanding on tongue tie. And there's not a lot of people who are really good at it. But if you're looking for a profession of people who really know, it's myofunctional therapists. Like that's my go to all the time. You want to make sure your tongue tie practitioner understands that tongue tie is important for all babies, not just those who are breastfed. Equally applies to babies who are bottle fed.
Yeah.
It's important for speaking. It's important for the developing our oral function, our teeth. It's important for breathing. My goodness, it's so important. Now, when it comes to reflux, it's really important we separate tongue tie from reflux. For some babies, you will get babies who have a tongue tie and a reflux, and the tongue tie is the direct cause of reflux. So addressing it properly, and I'll come back to that, addressing it properly can address and cure the underlying the reflux. We'll also get babies who have tongue ties and reflux, and the tongue tie has nothing to do with their reflux because they might have, let's say, a cow's milk protein allergy going on as well. You'll get babies with a cow's milk protein allergy or some other food intolerance or allergy and a tongue tie, and both are causing the reflux external symptoms. So we need to know what to deal with and how to unpick the different symptoms and the nuances between things to say which is more important, and which ones are going to give the change to the family first. What's most important to me after I've been learning about tongue ties for about 10 years now, and I keep learning because there's so much more coming up, is to first of all understand the tongue is 16 muscles. Okay, it's 8 pairs of muscles. It is the most complex group of muscles over which we have conscious control. Yeah, our heart is super complex. We don't think about that. We don't have to consciously make that work, thankfully. But with the tongue, we can get behaviors and functional things that look like tongue tie, but are actually tension within the muscle itself. So oral play and exercises with baby in their mouth, absolutely vital before and after tongue tie revision. And I have worked with children where it looked like a tongue tie, but we did a week of oral play first, and the tongue tie disappeared because it wasn't a tongue tie, it was just muscular tension. And I've seen babies where they've just gone straight for the tongue tie revision, no change whatsoever.
Hmm.
And that's because it's muscular tension. And so we're addressing the wrong thing. So it's not like things are not as simple as they look on the surface. We must always just triple check and go, yeah, we're happy with this, which is why now any of my clients, like I have an oral play course that anybody who comes into the reflux-free baby class, you do this because you know the way tummy time is a thing all babies have to do now. And it used to be, you know, when I was a baby, there wasn't such thing as tummy time because there weren't so many containers.
Hmm.
My world was the floor.
The floor
I
is just
had a
where we were. Yeah.
I had a playpen, but I was
Yeah.
free to move about that and explore that. And in that, I was getting my tummy time because I was
Mm.
physically moving my head, as opposed to so many babies now are left in rockers so that they can see the world and they're supported. They don't have to support their head themselves. And so tummy time is now the conscious effort to say, make sure we're not removing development opportunities for babies. You know, it's not saying all containers are bad, it's just saying let's make sure we're supporting babies at the right functional movement and development and support. For me, oral play is the new tummy time because, so do you go to the gym, Hee?
Yeah.
Yeah, so you exercise from here down.
Yeah, I feel like my brain gets a lot of exercise every single day. Like this conversation is kind of blowing my mind a little bit. Yeah.
And how
Yes,
much
I do.
do you do facial exercises?
Exercises, no, but I do like the guasha stone and dry brushing. I guess
Mm,
that's more for the skin rather than the
yeah,
muscles.
yeah. So exercises are chewing. Chewing is
Mm.
our biggest exercise. And certainly in Western culture, we have become accustomed to eating soft food.
Mm.
Lots of people will eat raw food and go crunchy, and that's great. And lots of people chew gum. Like chewing sugar-free gum is incredible for building up our cheek muscles. It's
Okay.
incredible. But we've got so many muscles in our face and we don't exercise them.
Hmm.
And this is one reason that, like, you know, we end up with the saggy jowl, is because we're not toning and exercising the skin.
Huh.
Like if we hold our tongue in the correct position, which is glued to the roof of the mouth, we instantly get rid of the jowl.
Yeah, okay,
Like,
so, I'm about to say the most, like, millennial thing ever, but I saw that on TikTok, and I did see the viral videos of people, like, sucking their tongue up, and it
mhm,
worked.
yeah.
So,
And this is
our
where,
natural resting position of our tongue should be on the roof of our mouth?
yep. And this is, again, this is something, a tip for all parents to start doing. First of all, remember,
Hmm,
it is our basic anatomical norm to breathe through our nose, okay? Because our nose has thousands of filters. It cleans the air. Like,
hmm.
it's so important. And when we breathe through our mouth, we don't filter the air whatsoever. So what you can do is when your baby's asleep, gently pull their lip down and see where their tongue is. Now, are you happy for me to show where it should be and what parents
Yeah.
should see? So it
Yeah,
should look
yeah.
like this.
Hmm.
Okay, so anybody listening on the audios, come and watch the video for that bit. You'll see where your baby's tongue should be. Now, that, when it's in the roof of the mouth, it creates this gentle pressure that pulls the arch down, which makes the nasal cavity bigger. So it actually improves our oxygen intake. We produce nitric oxide, which is like our supercharger, when we breathe through our nose, but not through our mouth.
Hmm.
It also develops a child's dental arch so that their teeth, funnily enough, become straight and they create space in their mouth for their adult teeth. So it's not just for infancy, it's like a lifetime of things. Breathing through our mouth is a skill babies cannot learn before the age of 4 months. Like, I don't know if your kids ever had a cold, but I remember my daughter first having a cold and she was like trying to, and just like breathe through your mouth,
Right.
it's open. And you're like, why can't you breathe through your mouth? They don't, it's a skill they have to consciously learn to open the throat at the back and breathe through the mouth.
Hmm.
And it's vital. It's absolutely vital for when we do have a cold. It's our backup system. But after your child has a cold, make sure they close their mouth again, breathing through their nose. They get better quality sleep. They get like the science, and I will grab some of the links and connect the publications for this for you. We are seeing children, older children with ADHD-like behaviors simply from poor sleep caused by mouth breathing.
Wow.
Okay, because when we breathe through our mouth, we get 18% less oxygen to our brain than we
Mm.
breathe through our nose, because this, funny enough, goes up and like literally we're putting oxygen straight into the brain. It goes across the blood-brain barrier immediately. So it like the amount of reasons why tongue position, proper tongue function, oral play is so important. It goes beyond like it goes beyond just basic feeding, which is so often where the focus is. And there's so many, I have heard, even still, so many parents come to me going, I was told to stop breastfeeding because my baby had a tongue tie. I was like,
Oh
no,
my
let's address
goodness.
the tongue tie.
Yeah. Wow. Okay. Gosh, this is just so, I think, eye-opening. I'm sure there's so many listeners out there who are like, what? So many things make sense now. Okay. Let's shift a little bit to remedies. Are
Mhm.
there any, like, I'm not going to say surefire remedies because remember, it's all like a fingerprint. So we're finding your baby's individual puzzle piece, but where should we start in terms of remedy? And then what are the options that are maybe evidence based that are pharmacological options, the medical options that we have?
Okay, so the surefire solution for every child's reflux is to find and address the underlying cause
Right.
every single time. And for some babies, they may not be able to get all the way to reflux free. For example, let's take a severe case where a child has a cleft lip or palate. Yeah. So they actually have a hole and a gap in the roof of their mouth. So their tongue cannot, they cannot reduce the air, they cannot prevent themselves from swallowing air. However, for these children, we can create the set of strategies and feeding behaviors and feeding support that minimize the air and therefore reduce the impact of reflux until they get round and have their, the surgery they need to have. I do believe that for every child, there is an answer. And I will mention, because it is so important, that if your child suddenly starts having reflux, especially if they're already on solids and they've been established on solids for a while, and they suddenly start throwing up, like proper regurgitating all the time, or at the same time every day, please do not be fobbed off with it's just reflux. Okay, it might be just reflux. However, it will still have an underlying cause that we can find, be it tongue tie or, where a child isn't maybe chewing their food correctly, or they're taking on too much air while they're drinking, or they're using, like I see kids using cups with straws. And every time they use a straw, well, the first part of that is air. So we actually
Hmm.
get children drinking lots of air when they start drinking fluids, and that could be enough to start reflux. So I don't want to scare parents. However, it is really important because I have seen too many cases where it has ended up being too late for some children, because sudden onset vomiting is a sign of a brain tumor. And
Wow.
so, and I have too many stories of it being too late. So get the answers.
Mm.
Like when we can tell a story that logically adds up and go, well, this is baby's behavior here, and then this is happening, and then that's happening, and so this is happening. It's like, okay, that all makes sense. So when you address the underlying cause, there's a chain reaction and it all goes away. If a child really had a brain tumor, taking any of those actions would not change it. And so, for me, 6 to 8 weeks is enough for any child to go through this process diligently, and we're able to piece the story together and tell the story and go, that all makes sense. Or we're still scratching our heads and going, right, now is the time to really ask the next level of questions.
Mhm.
So that has to be done first. And this is where the medical community, when they step up, are brilliant. However, it's been the medical community who have missed these children for 2 to 3 years, and then it's too late. So I also see a lot of children getting the pH probe, the barium swallow tests, the x-rays and all of that. And none of these tell us, for most children, anything other than they've got reflux.
Hmm.
We can tell that a child's got reflux. They are telling us with all of their patterns as well. So I don't believe in those invasive tests, except in extreme cases where, for example, a child might have had like a tracheal atresia. So their trachea actually wasn't connected to their stomach and they've had surgery. And then those tests tell whether their anatomical function is working correctly, or they need
Whether that
additional
surgery
support for
was a
that.
success. Yeah.
Yes, exactly. But for a child who simply has reflux, and I have so many parents come to me going, we've done all the tests, there's nothing there, we've checked out, there's nothing sinister going on. It's like, great, but your pediatrician completely missed the tongue time.
Mm.
Like, we always have to come back. This is my engineering degree is I don't know if you're familiar with the phrase KISS, keep it simple, stupid.
Yeah.
Like, literally, we should be able to piece the story together and make a logical story. And if we cannot make a logical story, then we need to go back and go, right, what else could be going on?
Yeah.
But we have to start with the simple things. And it takes no more than about an hour to 2 hours to get enough of a sense going, oh yeah, that's the story, I can see it here. When it comes to the pharmacological interventions, the only answer the medics really have is watch and wait,
Mm-hmm.
because it's normal and baby will grow out of it, or medication.
Mm-hmm.
And they have options of medication between famotidine, which is the H2RA, the histamine 2 receptor antagonist, which is a replacement for ranitidine, which got called off the shelves. And I will say, because you're a global podcast, ranitidine is still on the shelves in South Africa. It's still on the shelves in a few countries. And the reason it was called off the shelves in most countries is because of a carcinogenic contamination, which was never resolved. So that started in November 2019 and was off the shelves in most major countries in the Western world by, I think, April 2020. It's still in places. So for that reason, it's up to parents to decide whether they want to use it or not. Famotidine is interesting because it's allowed from birth in the US, and in the UK, it's not allowed until the age of 12 years.
Wow.
Yeah. With a clear statement I literally looked this up for an Instagram story last week, a statement on the medical literature that says we've got no proven use of this in the pediatric population at all. It's not safe for use in the pediatric population if you look up the electronic medicine compendium for the UK. So we have massive degrees of variation in countries around the world. And then the other one is the PPI, the proton pump inhibitor medications. And these are ones that end in prazole. So the active ingredient, you're going omeprazole, esomeprazole, pantoprazole, lansoprazole, rabeprazole, any of those, they all work the same way. And the only one which has got some history on being, and it's licensed for use under the age of 3 months, is liquid form, the liquid suspension of esomeprazole. That's the only one. Everything else, if you look at the literature and what the pharmaceutical companies themselves say, is don't use in babies under 12 months. So most of these medications, so famotidine in the UK, in the US, is licensed for use from birth. And all the PPIs, other than one particular variant, are all now being prescribed essentially off books. I can't remember what they
Off label.
Off label.
Is what we
That's it.
say. Yeah.
Yeah.
Wow. I'm a little shocked.
And then we have Gaviscon. Yeah, sorry, I skipped over Gaviscon, which is very often the first step, but forms a raft and so makes it more difficult for baby to vomit and often causes more digestive discomfort as a result.
Yeah, that makes sense. Wow. I'm a little shook. I'm also a little not. This feels very, it happens a lot where other
Yeah.
countries have different standards and, things that they allow and don't allow in particularly medicine and cosmetics and food and all sorts
Yeah.
of things.
And
Yeah.
it's what I will say, it's really like I don't believe medications should be the first port of call.
Yeah.
And I do believe they have a place.
Mm-hmm.
Yeah. So it's really about being comfortable with what we're trying to achieve from the medication and why. And I have an interactive medications guide that parents get when they join my reflux clinic membership.
Nice.
We go through all the medications, what each of them does, how they work, what are their side effects, what are the contraindications, how should they be used, and if you have them for your baby, what should you expect in terms of review, what should you expect in terms of a weaning plan, and all these sort of things. What's really important is that if a baby is in pain and suffering with acid burn in their esophagus, these medications So the PPI medications and the H2RA, so that's the prazols and the famotidine, they reduce the acidity of stomach acid so that it doesn't physically burn and damage the esophagus. Okay, so that is when they are beneficial. However, we shouldn't use them
Long term.
without a plan. Exactly. They are
Yeah.
not, they, even in the adult population, all the literature is no more than 6 to 8 weeks, no more than 3 times a year.
Yes.
And I meet kids been on these for 2 years with no review.
Oh, yeah.
Yeah. So we're not, the medical population are not telling parents the nutritional impact of these. They're not telling parents about the long-term potential issues with, community acquired pneumonia and all the other Clostridium difficile infections and so many other things that could be related. So parents aren't getting the ability to weigh up their decisions on balance. And I think that's really important for me. Like, I am very much about every single parent should have the information to make informed decisions, because that's all we, like, as humans, all we can ever do is make decisions based on the information we have available at the time.
Yeah.
Yeah. And for anybody who made a decision prior to hearing this and you got new information today and you're like, don't ever feel guilty, because I know that as a parent, every single one of us has always done what we thought was the best thing in that moment with the information we had at the time and with the resources, and the resources is our level of tiredness, our ability to think, whether we've eaten or not. All these things are really important. And so if you get new information, allow yourself to change your mind. Allow yourself to go, okay, that served us until now, or I did that decision and this is where we're at. Where do we go from here? And so it becomes a journey rather than looking back and going, oh, I wish I did that. And don't ever wish that you did something different, but give yourself the choice to go, actually, I want to read up a little bit more about this and make more of an informed decision. And if you're happy with where you're at, that's brilliant. Like, that's where we should always be. We will always feel more comfortable with ourselves when we go, I'm happy, like, I trust that doctor. I'm going to do what they say. And that's fine. And there's other people who go, nah, I just didn't like the way that person spoke to me, so I'm going to dig a little bit more. Whatever your reason is, it's good enough.
Yeah, I agree with that. I think you should really listen to your intuition. And that's not just about your baby symptoms, but the feeling that you get from your providers and the options that they present to you and the sources that they give you, or, digging into your own research. Okay, so I do have a question about the pH of the belly. You were talking about it changes it from, acidic to a little bit more neutral or basic. So that must throw off the pH. And then previously you had also talked about the gut health. So I'm wondering if there is a reason, or maybe there's data behind kids with reflux being on a probiotic to help rebuild that gut health or help improve that pH of the belly. Is that change in pH even a problem?
The change in pH is a massive problem, because when this is what causes a lot of the issues. So we primarily see our stomach as part of the digestive system. It's actually also a really important part of our immune system. The acid in our stomach is there to kill some of the bacteria we eat with food. So if it's not acidic, we're now eating bacteria and they go into our small intestine. And this is where there's lots of research around the long-term use of PPI medication and H2RA medication and heightened increased risk of small intestinal bacterial overgrowth, or SIBO, which is, SIBO takes far longer to resolve than it does to create. However, it does take time to create. So if your child is on one of these medications and has been on them for a while, I will say I've not yet met a child under the age of 18 months who has had SIBO, because and the kids who've been 18 months who did have SIBO, they were literally on the medication from 5 to 6 weeks of age. Yeah,
All
they
the
were on
way
the
through
medication
18
for a long
months.
time, pretty much. Yeah. So probiotics won't actually prevent SIBO, because probiotics can be amazing. And we also have to be careful, especially if we're using the PPI medications, because PPI medications are, and the H2RAs, so the gastric acid suppression medication, they also elevate the histamine levels in children, because histamine is the neurotransmitter that tells our body to produce stomach acid. And if the stomach acid is being blocked in any way, the stomach goes, more histamine, make more stomach acid. It's trying to communicate that all the time. So we elevate the levels of histamine circulating in our blood. Now, histamine is completely normal. It helps our body do so many things. However, we do have a threshold level of it. Okay, we have a DAO, diamine oxidase, is the enzyme that breaks down histamine. So, do you know the big glass jars with a tap on the bottom?
Yeah.
Yeah. So, if you leave the tap open, right, the tap open at the bottom is like, is our diamine oxidase, right? That's our ability to break down histamine. And so we can leave the tap open and pour water into the jug and it won't ever fill up because it's flowing at the bottom, until we do something that artificially increases the flow of histamine into the body. So now imagine we've got 4 jugs pouring water into this jar. We still have this maximum rate. The tap doesn't open any further. We only produce a certain amount of the DAO enzyme. And so we can actually fill that jug. And as soon as it overflows, we now get these allergic symptoms. That's what histamine sensitivity is. It's when the histamine in our bodies breaks its threshold level. And so it can flare for babies who are on these gastric acid suppression medication. Their histamine levels get elevated really quite quickly. And so if they have, there's so many other things that can contribute to histamine levels, like inflammation and tiredness and so many things. But we can get children who appear to be allergic to everything. And we can't figure it out. And they might have Sunday dinner and they were fine. And then by the time Monday comes and they eat the very same meal, it's actually leftovers, but they react to the leftovers. These are clues that it's a histamine thing going on. And the reason I come to this at this point of the conversation is because probiotics, the bacteria in our gut, produce histamine. So sometimes we get babies and they start on a probiotic and it's all with the good intention of supporting their gut health. If they're near a threshold level on their histamine issues because of ongoing PPI medication or ongoing H2RA medication, then it could be a trigger and it looks like they're allergic to something when actually they're not. It's a histamine equation. So again, this is where understanding and having all the pieces of the puzzle first gives us such a deeper insight as to what's going on. And so I really believe in solving reflux first. And for babies who are on medication, solving the reflux, then if they're not regurgitating, they don't need their esophagus being protected anymore. So we want the medication, and then we get to see what their body really does.
So if someone felt like their baby was having those symptoms, what kind of specialist would they seek out? Are they going to an allergist? Are they going to an endocrinologist? Who should they take their child to?
They can pretty much stay away from the Western system, to be honest. Find a functional doctor. Functional medicine. For children and toddlers, I've got a basic set in my weaning course, which combines a whole lot of stuff about the developing digestive system. And we need to look at, we need to find people who really understand it all. And I've yet to find somebody who's put it all together, including with the medications. So I have a basic course for toddlers on this. And then we can get so far, because what's really important is we address the reflux. If your functional doctor isn't looking at reflux as an underlying cause and doesn't understand tongue tie and things like that, we need to do those first, get baby off medication. And then for SIBO, definitely it's functional medicine, functional practitioner who really understands the different varieties of bacteria and can find really specific bacteria. And I say you have a lot more of support in this in the States than we do in the UK. I've got a good friend who's become a good friend from being one of these I can't believe that happened clients. The two of us learned so much from her daughter, and her daughter is probably 6 now, and I think she can eat 20 foods.
Wow.
Like, and 20 foods is not a lot. You want your kid to be eating 20 foods by the time
Yeah.
they're 6 months. This
Yeah.
child literally had a cascade of errors from the medical profession from the beginning. So many mistakes and so much learning for her mum and I. Like, her mum trained with me and now does this as well. And when she was going through supporting resolving her child's SIBO, she was importing the probiotics and the right support from the US,
Wow.
because we just don't have that level of knowledge in the UK. Functional medicine in the US is superior, I think, than anywhere else in the world. So while we have
Wow.
this really strong medical Western system, you guys have a really, really good functional medicine system as well.
Yeah, that's amazing to hear. I love functional medicine. Our team is we're really big supporters of functional medicine, and a number of us see functional medicine doctors kind of
Yeah.
as our primary care physicians. Okay, I think that we've covered so much, but I do have one final question for the people who are like, okay, great. All of this, or a lot of this, most of this applies to me. I have a plan of going forward, but in the meantime, I'm stuck with these really hard times where my baby is just inconsolable, and I know it's going to take time to get these appointments done. Do you have tips for parents, and how do they cope with these really hard reflux times? This is a time that if your doctor has diagnosed your baby with colic, then this is what you're going to call like your colicky time, right? Or that it's different than the witching hour, but those really hard kind of reflux times.
Yeah. So there's a few things. First of all, please follow me on whatever social media platform you're on. There's tips there. I post daily, Monday to Friday. Grab me on the stories. There's a Q&A box most Mondays. So come and follow, get information. If you can, get the book, The Baby Reflux Lady Survival Guide. If you have time to read, is fantastic. I've got online courses and I do one-to-one support as well. So we've always got ways to help. However, in the meantime, the first thing I would say is to breathe. Okay. It is the most stressful time. It's incredibly worrying. And I know this because my own journey involved 3 years of a relationship with postnatal depression. It was tough, it was low. And actually, conversing, you said, sometimes the mornings we were dreading things. I dreaded the night
Mm.
because I felt so lonely at night. I was like, my husband's gone to sleep and he needed to sleep because he needed to go to work. And I was
Sure.
scared that he was driving the next day. I was like, oh my goodness. But simply breathing, okay, our breath can be the first point of grounding, and it doesn't change what's happening in the world, but it does change how we can cope with it. The first most important thing is to focus on your exhale being longer than your inhale.
Mm.
That moves us from our stress state into our calm state. And so we gain the ability to think and to cope and to tell ourselves we are absolutely amazing parents and our babies chose us for a reason. So remember that always. You said it already, and I completely agree. Every parent is the world's leading expert in their baby. 100%. If you feel that your baby is more unsettled than they should be, you're right. Yeah. What you live in your life is reality. Don't have anybody gaslight you and say, oh, that can't really be happening. You can go, well, you might think that. And remember, you are in your life. Nobody else is. Ask for help is another one.
So hard.
And it's really hard. And it's also really, I found it really hard because my mom would tell me, oh, well, I did this for you. And this is how I parented. And you turned out all right. And it's not that I was trying to in any way shame my mother about how she parented me. It's just that right now, we have encyclopedias in our hands. We have access to so much more information than our parents ever had.
Mhm.
So remember that your parents, if they're offering, oh, I read this blog and I read that blog, Like, it used to frustrate me so much going, "Don't you think I've tried all of these things?" And if people want to help, kind of go, "Actually, ask your mum, your mother-in-law, your father, whoever is available to help. Do you know what? Can you hold them? You seem to be able to burp them. Let that be somebody else's superpower."
Yeah.
You know? So allow that help to come in and ask them to tailor it. Kind of go, "Do you know what? I heard about this chick on a podcast. Would you ever listen to the podcast? Look her up on Google, see what you find out." Get other people involved in the research as well. We don't have to do the journey alone unless you allow yourself to be alone. And I found it, I didn't know who to ask for help. And I didn't know, well, I didn't exist.
Mm.
So if you have found this podcast, just follow my Instagram, go there, first port of call, and you will realize you're not on your own.
Yeah.
And if you ask your friends, 50% of babies in the UK and the US have reflux. So
Wow.
you're most definitely not alone, but we often suffer in silence, telling ourselves that, oh, their child is fine at the minute, so they don't have these problems. We never know what's going on behind somebody else's closed doors. So be open with your friends, conversations. Go, "Do you know what? I'm having a really tough time, and I don't know if this is normal or not."
Yeah. Yeah. Gosh, you're never alone. Postpartum is such a journey. It's got its highs and its lows, and it has wonderful moments, but it also has a really hard moments. And just remind yourself that those are fleeting, right? They are temporary, and there is an other side to this. It just takes sometimes a lot of work, and that's okay. You can totally do that. So Anya, you've given us a lot of places that we can find you and follow you. Is there any other place that people can connect with you if they'd like to work with you?
So Instagram is great, and then my website, which is www.thebabyrefluxlady.co.uk. Sort of, they're the two main places. There's also Facebook and TikTok and all the other regular places, but they all point to the website. And yeah, I think we've got a special code for your listeners, Hee.
We do, and I will link that in the show notes for everybody to take advantage for that.
Brilliant, brilliant. Because what I will say is that there is an answer. There's
Yeah.
always an answer. And sometimes, this is not about parents not knowing the answer, because if I asked somebody to translate a book into Hebrew, unless you actually spoke Hebrew, you'd probably feel quite comfortable going, "I don't know how to do that." And that's okay, because we can all learn. Understanding reflux is the very same thing. You can't be expected to know this stuff unless you've learned it. And, think of me as your reflux dictionary. I help you decipher what's going on and read everything for your baby so you can do it yourself.
To find those perfect puzzle pieces.
Yeah.
This was such a fantastic conversation. Listeners, if you want to get in touch with Anya, you know how to do that. And we will link all of her links in the bottom. Thanks for joining us. I'll see you next time on the Birth Lounge podcast. Until then, head over to Instagram and find us at Tranquility by Hee and give us a follow. You can also check us out at thebirthlounge.com.